Have you ever had a patient come back to you saying, they no longer cover my medication, and you not knowing how to guide them? Well, let's talk Medicaid cuts, PBM reform, and how we as healthcare professionals can step it up with guest co-host Dr. Damien Fisher. Hi guys, welcome back to RT Share T, where respiratory therapists live out loud. With me, your host, Linda Fry, the Asthma Lady. Yes, welcome everyone. Welcome to anyone new, and I am so excited because I have Dr. Damien Fisher back as guest co-host. Yay! So Dr. Damien Fisher is a unicorn. He is back and he is, for those of you who don't know, he was on the show once again already, and he is a very accomplished community pharmacist as well as an asthma educator specialist. Yeah, so he is a friend, and I'm just so happy to have him in our network to talk about these topics. Dr. Damien Fisher, appreciate you coming back to the show.
No, I was just saying thank you. I really appreciate it as well.
Yes, 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 yes. So, okay, so the direction of this show, guys, the episode for this episode, we are going to try to figure out what are we going to do navigating and helping our patients in with all the news around the Medicaid cuts and trending topics such as PBM reform, which we're going to be talking more about this in this episode. And so we know that a lot of our patients, especially in underserved communities, are on Medicaid. So this is going to have quite an impact on those that rely on Medicaid in regards to healthcare services. And we're just trying to figure out what we can do to help patients. And so that's why I have folks like Dr. Damien Fisher, who's here to explain a little further what we can do to navigate. So we're going to jump right into this with the questions. Dr. Fisher, in simple
hmm
terms, what is PBM reform and why should we care?
So the the thing about PBM reform, I let me just say, I think it's going to take a long time because I think the PBMs are going to fight back against
Right.
the reform, which
Oh, can we break down the acronym? Because I'm using it too. PBM
are
reform.
so pharmacy
Pharmacy.
benefit managers.
Mm-hmm.
Um, and so basically these pharmacy benefit managers, what they do is there's something called spread pricing or spread pricing, which mandates the PBM to show the difference, what they change insurers and what they pay pharmacies. So
Okay.
they're basically charging one thing to someone else, getting a profit from basically the patient's co-pays and what they would pay for the pharmacy because of already contracts that have been
Mm-hmm.
established with some of these insurers. So they're making a profit. But the thing about
Okay.
PBM reforms, they're trying to make it basically transparency between
Okay.
everything. So if lisinopril costs, 0.0001 cent per tablet, that is how much a patient should pay times 30 days, that
Okay.
one tablet per day, and that's what they should pay. So there wouldn't
Okay.
be so there's no discrepancy, and they're not getting any rebates, they're not getting any kickbacks,
Okay.
they're not gaining any money. But the problem is the PBMs are going to fight. They're
They're
going to
gonna fight it.
basically say, yeah, they're going to basically say, okay, well, we're going to have to make a profit as well. We're like the middleman. We're the one that negotiates
Okay.
these contracts. And, sometimes the rebate works well for the patients. But the problem is that those rebates only work well for certain drugs, then some of these drugs
Okay.
are not chronic disease state management drugs.
Okay.
And
Okay.
so we're not and because of that, there is no transparency of how much gross profit they're making on certain medications. For example, let's take
Okay.
GLP-1s, the new hotness, right?
Okay.
The new drugs that, fix everything, whether it's through dermatology or whether it's through losing weight or whether it's through improving your diabetes, cardiovascular risk, improving kidneys, whatever have you, GLP-1s seem to be working well in a lot of different areas, but they're
Okay.
putting a lot of restrictions on what can get approved and what cannot get approved for certain things. For example, our health insurance. When GLP-1s came out, we had approval for weight loss management and diabetes. Now,
Okay.
you have to have a diagnosis of diabetes in order to even get considered for the approval through your insurance.
Okay. I see. So
And
it's more
for
steps. Like you need
yeah,
more
more steps.
to
And
qualify.
then and then the other thing is what they also do is in order to make it you to jump through all these hoops. So there's formularies and there's tiers. For example,
Yes.
you have to be on metformin for a certain amount of days. You just can't be prescribed Ozempic or Manjaro. You have to be on metformin for a certain amount of days. You had to
Okay.
be diagnosed. You might had to have a comorbidity on top of having diabetes in order to get GLP-1. So they make you jump through all these little hoops in order to
Mm.
get the medication that actually could cause major differences in improving your overall quality of life with diabetes. And they're
Okay.
basically streamlining these mandates where they're not going to be able to jump through all these hoops because what the price is what the price is. So there's no
Okay.
point of
Going
going
through
through
all
step
all
one,
that.
step two, step three.
Okay.
Is now it's going to be this is what the prescriber prescribed, and this is what
This
I'm
is
going to
what it
get.
is. Okay,
Yeah.
because on the okay for asthma folks, because it seems like
Oh,
we
sorry.
know
I should
no
have
no no
brought
no
I
no
brought
that's
asthma as an
fine
example.
that's fine because you already you spoke on a trending meds, which is that Ozempic. We all know folks are trying to lose that weight, the diabetes. These are the trending meds, but when it comes to asthma, we know we see this on the biologic end because I see that a lot. You got to go through so
Beautiful.
much to
Yeah.
get approved. It's such a tedious process because I
Hmm.
used to help manage the asthma clinic, and to get to even get approved for biologic,
Hmm. Hmm.
you have to go through several hoops and still may not get approved for it.
And and another point that you beautifully just segued in is that with this PB reform, it also eliminates the contract negotiations and stipulations for certain insurances. For example,
Okay.
I have Blue Cross Blue Shield, right?
Mhm.
If I want a biologic or a specialty medication, I must go to Express Scripts.
Okay.
That's it. I
That's
can't
what
go
it
to any other
is.
specialty medication, specialty pharmacy. I can't go to UTMB specialty pharmacy. I can't go to Humana, Optum. I can't go anywhere else besides Express Scripts. Well, with
Okay.
PBM reform, they're eliminating that. It's
Okay.
no segue. This is what's going to happen. You can go to it's a free for all. You can go to any mail order, any
Okay.
specialty pharmacy that you would like. Because guess what? The price is what the price is. And so they're not saying there's not going to be copays anymore. All I'm saying is
Right.
they're not going to be able to dictate based
Where
off
you can go.
contracts and negotiations already established between the PBMs and these specialty pharmacies and these mail order pharmacies. So
Okay.
that will allow, because of free for all, they actually might produce more competitive pricing between all the
Mm-hmm.
pharmacies.
Bring
And
down
this
the
will also
price.
Yep, and this will also allow those independent pharmacies, not those commercial, not Walgreens, not
Mm-hmm. The
CVS, nothing
mom and
like that,
pop.
but it will allow these independent pharmacies to actually have more say so in the game, more foot, more have a
Okay.
more established foothold, and be more competitive. So they're like, well, we're trying to get more into the game. So hey, we might have Nucala because of this new FDA approval for COPD, even though in my opinion it's not, I don't think it's better than Dupixent. But the point I'm
Right.
still trying to make is that now they can say but now they can actually maybe sell it for cheaper than commercial because they have,
Okay.
they don't have to have as much quantity as Walgreens or CVS. So independent pharmacies are now, if this PBM reform actually into play, they'll have more of a stronger foothold in trying to serve their patients and not where patients are have to directly go to specialties or certain mail order pharmacies to fill their prescriptions.
Okay, so we have more of a choice. That's what I'm hearing. And the
Does that make sense?
potential, it
I
does.
did.
It does. And especially amongst the mom and pop pharmacies, which I know very well because I used to work for one back in the day. So I understand everything you're talking about. Okay, so that's great. I like the way how you summarize what that means for us, the everyday person, and how we can explain that to patients. And hopefully it works out. I know it sounds like it's gonna take years to go in that direction.
I just don't see this happening in 2026 or
Uh,
2027
you
at
know,
all.
yeah, we just gonna put the prayers up and hope that we get in that direction. But at least we're talking about it though, and hopefully we'll get more of a push. So as a pharmacist and asthma educated specialist, what are you seeing in your community with patients affording medications or medication adherence? So what are you seeing in, I know you're in Texas and as a community pharmacist.
So one thing I'm seeing is so there are a lot of institutions that have something called hardship waivers. And I
Okay.
would really and I'm not talking about Kelsey Sibo or Kaiser Permanente. I'm talking about these institutions that actually have their own specialty pharmacy and they're not as big as Express Scripts or Optum or anything like that. But they have
Okay.
these things called hardship waivers. And these
Hardship
hardship waivers are
waivers.
based off federal poverty limits or
Okay.
federal poverty level. And so, if they, for example, we have a hardship waiver for our patients, and they have to reach 400, right, for a federal poverty level. And so,
What
and
400?
basically,
What does that mean? 400
so it's like a
thousand?
400 point scale.
Ah,
It's a point
okay.
scale.
I thought you meant they needed $400.
Some no, 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 no.
400 point
So
scale. Got you.
yeah, so and it's based off a variety of different attributes, characteristics, but it's not a credit score or anything like that. It's
Okay.
we just take someone's name, date of birth, and we have people just calculating what their FPL is. And so based off their FPL, we can do something called hardship waiver. For example, on
And
certain medications,
I'm sorry. What's an FPO?
also the
FPL.
federal poverty level.
Okay, federal poverty level.
Poverty level.
Got you.
And so these these certain institutions like UTMB and these entities that are they have these certain programs for certain medications that they have. So for example, we have a 340B pricing. 340B pricing is basically saying, are you affiliated with the academic institution, which we
Okay.
are? And because we're affiliated with an academic institution, we can get drugs at a lower cost for some of our patients. And
Okay.
some of these drugs, because we can get at a lower cost, we don't want to make, I wouldn't say a killing, but we don't need to make such a profit where it's so affordable for us and not affordable for the patient.
Okay.
So let's just say a drug like Nucala. All right, where we started on that. We started on that road. Let's go with Nucala.
Yeah.
For example, if we can get Nucala for 5 cents per injection, right? We're not going to charge the patient where they're paying almost $100 a copay because they're on Medicare Part D on a very on a sustainable plan, but not a plan where it's sustainable for the patient to pay $100 per injection.
Mm,
So instead of making that huge markup, we would put them on our hardship waiver
okay.
and we would charge them $10 per
Okay.
injection because
Okay.
we're still making a
You're still
huge
gonna make
profit.
your money. Right. You're
Right.
right.
And
Right.
so, yeah. So, I mean, again, am I saying that's every institution? No, but there are a lot of institutions throughout America, throughout this
Hardship
country,
waiver.
like certain health entities where they have these hardship waivers. The only thing
Okay.
about it is you're going to have to ask, and
Okay.
so
So,
and that's proactive of the patient.
okay.
There are
Would you,
charities.
I'm sorry to cut
Mhm.
you. So would you advocate for more of the hospital pharmacies that would have something like a hardship waiver?
So, yeah, if we're talking about biologics, I would advocate for hospital specialty pharmacies if they have these type of programs.
Okay.
And the thing about it is these programs they're there, and sometimes the patient doesn't know. And now,
Okay.
also to say this about that, prices for drugs fluctuate all the time, right?
Right. We see
So
that.
6 months, up until this point, we may get Nucala for 5 cents per injection. Again, I'm being very facetious.
Right.
But the next 6 months, it may cost us $95 per injection, right?
And then you gotta
So
adjust.
yeah. So, but we try to do what we can do for the patient on a certain period of time, and
Got
these
you.
these prices do fluctuate. And now, will there be such an increase like that? Probably not. But I just want to make sure that message does get across that
Mm-hmm.
prices for drugs will fluctuate. So
Right.
that might not always give a certainty of getting these
The
medications
pricing.
every year. But I can tell you this, if institutions are doing these programs, they are basically already allowing themselves to be in to say, okay, you can get this drug for 6 months, and then we will reassess your FPL after 6 months.
Okay. Okay.
Does that make
Okay.
sense?
Yes. Yes. And good to know for folks that so it gives you the opportunity to plan ahead, like
Yes,
and plan
most definitely.
ahead and then while especially while you guys are adjusting price, the pharmacist. And it does make sense. It does make
Right.
sense.
And
Thank
and
you.
then also, yeah, also the
Okay.
other programs, there are charities, donations, or there are programs. I mean, GoodRx is okay. It's a good discount, but
Right.
sometimes, there are other discount programs. And
Mm-hmm.
another thing that these institutions use, they use this program called Cover My Meds.
Cover
I
my
don't know.
meds. Okay.
Yes, Cover My
Cover my
Meds.
meds.
So these institutions use this thing called Cover My Meds, and we use it as basically a checklist on trying to get drugs covered by certain insurance companies. Now, if they're not covered, that allows us to do an appeal, and also that allows us to
Okay.
find different avenues to get the drug cheaper.
Okay, you drop it some gems here. Okay, cover my meds. I'm taking mental note for myself too.
Oh, yeah, yeah.
Okay. So thank you for sharing that. So, okay, and I think you actually just answered some of you answered this question. So for those of us that are healthcare professionals who aren't pharmacists, right? What should we look out for during open enrollment or routine patient education? And you already mentioned like insurance status and mentor. Oh my gosh, I'm tongue twisted today mentioning those programs. So yes, go ahead.
So so other things you can look out for, I would say, when you're signing up for your insurance, right? You want to look out for your different tiers and of your drugs. All right.
Okay.
So there's tier one, tier two, tier three, and until PBM reform actually happen, these formularies are going to be that way. Now,
Okay.
what you want to look out for, what type of drugs are covered in tier one, tier two, tier three. Now,
Mm-hmm.
that's going to take some digging, right?
Okay.
And you want to find out if it's an HMO or a PPO as well. These type of things are very important because it will widen or will broaden the number of drugs that fall into each tier. The
Okay.
next thing you want to look out for, what is your copay for each tier? So, and then
Okay.
the last thing you want to look out for is what are your preferred items and your non-preferred items. So
Okay.
these type of things can be as accessible when you start signing up for these insurance plans. You can tell them, I would like to know what's considered in my tier one, tier two, tier three. They can
Okay.
send you, or they can give you access to an online resource, and they can give you a better idea because you
Okay.
want to know that going in to seeing your
Right.
primary care provider, your pulmonologist, or anyone prescribing an inhaler. Because there's nothing like you saying, okay, I need you to be on smart therapy,
And
but
then
Symbicort,
they don't cover it, right? That's a
right.
mess. It's a mess.
Or they'll you've been getting Symbicort, but they
And
won't cover Symbicort and they'll
anymore.
cover Dulera.
Yes, 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 yes. We
So
see that a lot.
yeah,
Yes.
and then the other thing is, if you are in the mature population, I don't like calling anyone old,
Right,
but
right.
you are, yeah, if you're in the mature population, you want to know what's the policies about nebulization? What's the policy about nebulizers? Because
Okay.
your nebulizer drugs, right? Your actually nebulizer machine should be covered,
I think you
but your
get
nebulizer drugs,
one a
yeah,
year.
you get one.
One a year.
Yep.
Hmm.
Yep. But your nebulizer drugs is some of them can be very expensive where they'll
Oh.
only cover up to 80% of the actual drug and you're on hook for the 20%. So which is different from a copay per
Mm,
se. So
okay.
those type of things you also want to understand when you start signing up for these insurance plans. And
Okay.
I'm gonna say it like my dad said it. Sometimes quality is better than the actual cost. So if
Okay.
you want quality, you might
You're
have to
gonna
pay
have
a
to
little
pay
bit
for
more.
it. Yeah. Okay. Okay. So that makes sense. Definitely. So if someone has a chronic condition, we're telling them before open enrollment time, which is around, what is that? October, November? Open enrollment.
I thought
Trying
it
to
was
remember what time.
October.
October, right? Okay. So
I thought,
October. No, I think you're right because I know it's in the fall, October, November. So yeah, that sounds about right. Um, we want to tell those with chronic conditions to do the research, start the digging, to see what is on the formulary list. It's to making sure that what they're usually on is still covered, right? And okay, okay,
because you yourself, you're your best advocate.
advocate.
Yeah, because unfortunately, there's not a particular healthcare provider that. I mean, there are pharmacists that will assist you step by step, but only you know what
What you need.
medications or what you need,
Yeah.
unless you have like a personal pharmacist with you step by step.
Yeah. Oh yeah. Okay. So yeah, that's a great tip. So for those of us, so what are some real tips? And you just mentioned a few. So what are some real world tips or programs healthcare professionals can share with patients who say I can't afford my meds anymore? So and you mentioned the good RX, cover my meds. So yeah, anything
So I
additional.
mean, I really would like patients. So, for example, Kroger had a beautiful program, but they just got rid
Okay.
of. And
Really?
but yeah. So, there are going to be other pharmacies that will probably take up this program. But they
Okay.
had a program where you would pay, I think, $90 a year, and your most of these drugs, and they would give you a list of
The
drugs
list.
that
Okay.
were on their $4 and $12 program where you can get 3 months worth. And as long as you pay that $9 a year, you were enlisted in this huge drug list program. For example,
Okay.
yeah, for example, like your ICS therapies, your Flovins, your combination drugs, Advir, also Dulera, instead of paying like $50 to $75 per copay, if you were part of this program, you would pay like $25
Okay.
for getting an inhaler. Now, there are other
I'm not mad
pharmacies
at
that
that.
are taking up this type of annual program to be
Okay.
enlisted in, but Kroger just got rid of it. I would also be hugely involved in some of these charities and donations. So there's actually a website, I just don't remember off the top of my head. I can
Okay.
send you the link later,
Okay.
where they
Not
will
bad though.
show you different charities that actually get drugs that are either about to be expired or drugs that
Okay.
get donated, where you can be a part of this charity program, and you would have to go to the certain sites, and they will give you the medication as long as you have a valid prescription.
Okay. Okay. That's a good one to know about. So hopefully, yeah, if you send it to me, I can add that in the description if you
I
remember.
will. I will.
Yes, yes, yes. Okay, so it sounds like okay, because you said a few things and I want to rewind back. So for go ahead. So for us to help patients navigate through potential, cuts that are coming up and navigating through um pricing of, prescriptions. You're basically just saying that we have to prepare them in advance and finding these specific programs that will help them, assistance program, online. What is the best thing? Where's the best place to send folks? Let's say, uh, I'm trying not to say the word old, mature. So what's the best tip for us to give to them? And because it takes them, it's harder for them to go online and check a specific website, or they may not know how to navigate like that. So you would tell them to go to their pharmacy or
Well, so to tell you the truth, I am a big advocate for independent pharmacies. I think they spend
okay,
more time in the mature population.
okay,
They are able to break down stuff and able to spend time getting the price more affordable for the patient.
okay.
They
When you say
it,
independent, I'm sorry to cut you off because I'm making sure that it's clear. When you say independent pharmacies, you're talking about the mom and pop pharmacies, not the big.
exactly.
Okay,
Exactly. Or, if you live in Johnson City, the Johnson City Pharmacy that's been in business for the last, 50 years.
gotcha.
These independent pharmacies are not commercialized. They're not Kroger. They're not
I
HEB. They're
gotcha.
not Randall's. They're not Safeway, CVS, Walgreens, Eckerd's, whatever have you.
Mm-hmm.
They're not the commercialized pharmacies where they're worried about the quantity and volume per day.
Gotcha.
These independent pharmacies, they're more worried about the community they actually serve.
Mm-hmm.
Uh,
Okay.
I'm not dogging commercial
The bigger
pharmacies. All I'm
ones.
saying is that the volume that they do, sometimes they cannot um, uh, independently focus on particular patients. Whereas these independent pharmacies, because of the volume that they do, they don't mind because they know they're building a relationship.
Mm-hmm. A
They're
long-term
building,
relationship. The rapport.
yeah, they're building the community around them, and they can affect their community um,
Gotcha.
more streamlined, basically. Um,
Mm-hmm.
so the that's the first thing I would do. The second thing I would do is, if they're not computer savvy, there are church programs,
Okay.
and
Communities of faith.
YMCA also has
Okay.
a couple programs where they'll go over how to sign up for Medicare Part D, or they'll go
Mm-hmm.
over about what medications are more affordable through certain discount programs. There are also a couple online sources, but there are educational resources that are available at your local recreational centers, rec centers. Now,
Okay.
of course, every rec center,
It's
YMCA is a little
different.
different, and
Right,
I
right, right.
can't say it will
Yeah.
always be there,
Right.
but that's where I would go first,
Do
especially
the
for those that are
digging.
not internet savvy. Independent
Mm-hmm.
pharmacies, I would go to your local YMCA. There are churches all over the United States that want
Mm-hmm.
to be serving the community, where they can
Yes.
give these educational seminars,
Yes.
so they can help their mature population.
Love it. Excellent. Okay. Thank you so much, Dr. Fisher. This is your time to plug. Plug away anything you have going on. How can we find you? Yes.
So technically, I work within the community, but I'm also a dermatology, pulmonology, clinical pharmacist. Dermatology is a little
Mm-hmm.
different.
Okay.
You know, I just don't counsel on Botox and aesthetics. I also do biologics.
Okay. All
Um,
right. All
yeah.
right.
So, but the thing about it is what makes it so important and why, I am so in awe of you, Linda, is that the biologics that in dermatology also cross over into pulmonology.
Yeah.
And for us as clinicians, educators, we need to understand that we're not only helping patients with pulm issues, asthma, COPD,
Mm-hmm.
we're also helping issues with the dermatology as well.
Yeah.
So
Ex
the
yeah.
so drugs like Dupixent, for example,
Mm-hmm.
crosses over
Crosses
that
over.
multiple times.
Yes.
Because of atopic dermatitis, it also treats
Yes.
asthma, it also
Yes.
treats COPD. We have
Yes.
a lot of
Yeah.
geriatric patients that, yep, we have a lot of
Mm-hmm.
geriatric patients that have COPD and also has AD issues because of other comorbidities that they may have.
Mm-hmm.
And so, one of the things I do here is do a lot of biologic training on the
Okay.
devices, the counseling, and I
Love it.
also do a validated questionnaire where I assess patients with pulm issues such as
Mm-hmm.
asthma or COPD, and
Gotcha.
also I do a validated questionnaire for their skin conditions too.
Love it.
Dermatology clinical pharmacy is a new hip thing. We're
Mm-hmm.
starting to grow a lot more. There's only like 25 or 30 of us in the whole entire nation.
You a unicorn.
Um,
I said you was a unicorn from day one. I know what I'm looking at.
Yeah,
From
I
day
guess I
one.
do like I like the challenges and the obstacles, but I
So do
think
I.
one thing that makes your show so good is that you're not only educating, the underserved, but you're also educating the clinicians that
Right.
actually
Yes.
need this information in order to reach more
Correct.
patients. So I
Yes.
do want to applaud your efforts and
Oh, thank
uh,
you.
trying to improve the outcomes of our patients and our providers and our clinicians. I think, what you're doing is great. And I really hope, when another big topic comes about, I hope you add me on at
Of
another time.
course, of course. You are a unicorn, and I have you in my back pocket all the time. So I always knew I had to have you on. And you just gave a plethora of gems. You don't even know because it's always I as a clinician never want to flat leave a patient. Like I just don't have any resources. I don't know where to tell you. And I know when I speak to now, as I'm connecting with other clinicians, I feel like sometimes they feel helpless. Like they just don't know what
Right,
to tell patients. And it helps with patient engagement to be able to have the dialogue and then be able to say, hey, listen, I have some options for you. We may have a solution, and work together. So I love this
right.
type of talk. So yes, thank you so much, Dr. Fisher, for your time. I'll put your social media stuff in the description. Guys, thank you so much for being here with us and know that we are growing together. We are here on most podcast platforms on Wednesdays, unless I'm on vacation. And
Yeah.
we are on to YouTube on Thursdays, guys. So much more to come. Enjoy your summer and see you next time.